We are very grateful to have him here. He was there last time with so many questions, and now again, once he finishes, I'm sure he'll give us some questions. Thank you, sir, for coming.
Oh, thank you. I recognize many of you from February, so it's wonderful to get among friends. And when I found out, I told you when I was here in February, I knew I was coming in November, and I said if we can get together, we should. And then as time came closer, I reached out to Dr. Gadgil, who worked with you guys from the organization so we could set this up. And we certainly thank the sponsors that have helped us actually make this a reality as well. Because we're very appreciative that in a rare disease we don't have a lot of friends, but we group together for this very reason so that we can learn together and make TSC better. The plan for today is, when it comes time, I can introduce Dr. Jesty, who came with me as well. Graciously, I said, hey, I'm doing this meeting with families, do you want to join me? And she instantly said yes. And so I'll talk for about 40 minutes or so. I'm going to focus on epilepsy and sleep today, as it applies to TSC, and also some just general concepts as it does with epilepsy, because I find as I work with families, a lot of times when you go see the neurologist, I get the sense that it's very confusing what we do. Why do we choose one medicine instead of a different medicine? Why do we need an EEG now but not later? Why do we need one later when we didn't need one at the beginning? So I want to talk about some just general epilepsy things so that you as parents, A, can understand what's going on, and then two, when you go to see the doctor, sometimes you'll have questions, and hopefully this will help you know how to frame those questions to the doctors to understand how they're treating your children. And then I'll talk about a little bit of sleep as well, because I feel like we don't talk about that very much in TSC, and it's a big, big problem. And kids who don't sleep well have more seizures. Also, children who don't sleep well mean that parents don't sleep well. And parents who don't sleep well fight more and are unhappy. They separate more. There's a lot of stress in the family when there's sleep problems with the children. So I want to talk a little bit about sleep. All right, so and then after we're done, we won't do a lot of questions for me right away. And then we'll have Dr. Jesty take about the same amount of time. And then we'll spend the last half hour, 45 minutes just doing questions with you guys. All right, so first we're going to start with epilepsy. And I showed this slide last time, but I added more in here. Sleep problems are about 50% in patients with TSC, and then epilepsy it affects almost everybody with TSC. We start to pick up some exceptions to that, but by and large, most of our patients, if you have diagnosed TSC, you also have a diagnosis of epilepsy. It occurs very early in life. Usually our patients start seizing before they have their first birthday. About 2/3 will have a seizure, at least, we have the big seizure this time, and then we have the little seizures maybe every day, or various combinations of that. And so that's what we deal with in tuberous sclerosis. We care about epilepsy not just because the seizures are a problem in the family, but they have big, big time impact on other parts of the brain. It has big time impact on development and learning and speaking. It also has big time impact on autism. And these are just two slides that I often show the doctors, showing that patients without seizures compared to those who have seizures have a lot more autism, and patients with seizures have less developmental improvement over time compared to those patients who don't have seizures. So now backing up a little bit backwards, what is epilepsy? This is the definition. Basically, it's sudden, unpredictable changes in how the brain can work. And it may or may not include things you can see from the outside. So it can be staring where the patient doesn't respond. It can be funny little twitches of the mouth or the face. It can be funny little jerks of the eyes. Or it can be a huge explosive seizure where everything's moving, the child doesn't respond. And that's what we call a grand mal seizure or generalized tonic-clonic seizure. And we'll talk about this electrical activity of why they occur. It's the fourth most common neurological problem that the brain can have. So we have strokes, we have dementias, and we have migraines, and then after that we get epilepsy. It affects all ages and has many different causes, but we're going to talk about TSC specifically. And part of the problem is variable. Some people have maybe one seizure and they won't have another one for several months or years. Other patients will have 10, 20, 30, or 50 seizures a day. So it's very variable. The brain, one nerve talks to another nerve through electrical conduction. Just like you have to have electricity in the house, our brains work by the same principle, even though it's on a very microscopic scale. One neuron sends an electrical signal to the next. What happens in seizures is those signals start happening as a short circuit where they just keep happening over and over and over again. And that obviously is not how the brain is designed to work. And it's that circuit that causes the patients to have jerking or for them to stop responding to people around them. Why do they occur in tuberous sclerosis? Well, we've known the genes that cause TSC now for more than 20 years. And then it was shortly after we found those genes that we found out within the body what those genes are in charge of. And they are in charge of controlling this protein here called mTOR. mTOR is a master switch for the body. It tells the body when things are supposed to grow and when they're not supposed to grow. And in TSC, they're allowed to grow without having that control anymore. In addition to that, they also control how cells survive. So some cells are supposed to die on their own, but this controls whether they do or don't. And then what we understand in the brain is that it's pretty important for how these nerves find their place in the brain and talk to each other. And so all of those things require mTOR, and all of those things are not working correctly in somebody who's missing a TSC1 gene or a TSC2 gene. Structurally, we can see this when we do either CAT scans or MRIs of the brain, and they can get tumors of the brain, which are called SEGA. This happens in maybe 10 to 20% of patients with TSC, or they can get these little nodules, and these are often present when they're born. These are called subependymal nodules, or SEN, or you can get these scars of the brain. These scars form before the child's born, and these are what tumors are. They're these white spots that we can see on MRIs. You can also oftentimes see them on CAT scans, but they have a different appearance. So we historically usually show them as examples on MRIs. Now, when we look at the TSC brain under a microscope, in this case, this actually is not a human brain. This is a mouse brain that has TSC. What we see is that normally you'll have a nerve that looks like this, and it has lots of little branches to go out and talk to each other. In these mice that have TSC, what we see is that the body or the main part of the nerve is too big, and then you see that they lose a lot of those extra branches, and so they don't have the right ways to communicate with each other. And this is showing you how their bodies are larger over here. And then when we look at this, even at a finer microscope, what we see here is how they have these little tiny appendages to talk to each other, and you see in a TSC brain that those appendages don't form correctly. When we look at it in a cartoon sense, this is what happens. We have the signal comes from a different let's say from above, and it comes down to the main end of that very end of the branches. And in those branches are a bunch of molecules that's how one nerve talks to each other. And it releases those, and then there's another nerve ready to receive that signal. Okay, and this is what we call the postsynaptic dendrite, which is like the branch of the next cell. This is what happens in normal situations. What we find is when a nerve talks a lot, the listening one actually starts putting more receptors out. And so this is what we call potentiation. It means it's a stronger link between one nerve and the other. And over here, there's other nerves that say, hey, you're not supposed to talk as much. And so they actually get rid of a lot of the listening parts, the receptors. And this is what we call depression, long-term depression. Both are important in how a cell works as it talks to the rest of the brain. We have to have some cells that talk a lot, and we have to have some cells that don't talk very much. And in both situations in TSC, and this is done again in cells that look like neurons, we find that TSC cells, some of them are talking too much, and some of them are talking too little. And that's why, even on an individual nerve basis, we can see this. Now, we can't measure in a human individual nerves. We can only do that in the laboratory. So what we actually do is we measure big bunches of nerves at the same time. And that's what an EEG does. We put the sensor for an EEG on top of the head. It listens to the nerves that are underneath. And if we have a bunch of the nerves that are talking too much, or too little, then we can actually measure that on the EEG. And so that's how an EEG works, is we put a whole bunch all over in different spots on the brain, and we listen everywhere to see if there's too little or too much talking going on. And when there's a normal amount, we'll see that there's kind of some activity here, but nothing super exciting, nothing seems to be abnormal in this situation. Parents, I don't expect you to understand how to read an EEG. When I first started my medical training, this looked like a kindergartner's writing on a piece of paper. It looked like scribbles. But we get good at doing it after practice of seeing what's normal and not normal. And here you see that we see lots of these little kind of spiky things. That's when there's too many neurons underneath that EEG part where they're talking too much. And so we see these spikes here. And so this is that normal EEG. Now, how are EEGs useful? Well, they are useful because sometimes we need to figure out if somebody's more likely to have more seizures. And let me give you an example of that. If you remember in February, I talked about how we start doing EEGs in babies to see if the babies are going to start having seizures. Well, that's one reason why we do that. We do that to see if they're going to have more seizures or when the seizures are coming. We also use it because a lot of times things that kids do in TSC can look like a seizure when they're not at all a seizure. They're just an abnormal behavior. And so we can use the EEGs to tell us that whatever the child's doing, if they're staring, are they daydreaming? Or are they having a seizure? Or are they super focused on their toy to where they don't listen to you? Or the television and they don't listen to you? Versus is their brain having problems listening? We use it to identify seizure types, and I'll show you in a minute why that's important. Because there's many different seizure types. And we also, when we're starting to talk about epilepsy surgery and we need to find out exactly where a seizure is coming from, we use the EEG to help hone in on where that spot might be. And then we add additional tests to actually make sure that we're right. So when we use treatments, our goal for treating epilepsy, we use medicines, we use the diet, we also do epilepsy surgery, all with the goal of stopping the seizures. That's our number one goal. Sometimes we don't achieve our goal, but that is our goal always, is to try to eliminate them if we can. At the same time, we also try to minimize any of the side effects from our treatments, and many of our medicines do have side effects. We try to identify and address epilepsy-related comorbidities. We know that there's high degrees of anxiety, high degrees of depression, high degrees of autism and TSC, so we try to use our treatments for epilepsy at the same time to address some of these other things, or at least be aware of them in case it changes what we do. And then ultimately, if we can't stop the seizure or no matter what else is going on, at the end of the day, we want to make life better. At the very least, that's what we're trying to do. So sometimes we don't get rid of the seizures completely, but maybe we can get rid of the worst ones. Or maybe we can make them so they're less frequent, so that you have some days where you actually don't have any seizures, even if we can't get rid of them completely. So we use all of this to help us decide on how to treat a child who has epilepsy. Now we have lots and lots of different medicines. We have some that go back to more than 100 years old. And we have some other ones that have been around for 50 years that are still what we call oldies but goodies. And then we have lots of newer ones that have been discovered in the last 30 years, and we use all of these in TSC in our clinic for various patients who have particularly difficult to control epilepsy. Some of the newer ones we have that just got approved in the United States. Last month we got approval for the cannabidiol, which is the cannabis-related treatment. I'll talk about everolimus here in a minute. And then we have lots of these other ones that I'm sure you guys have heard of. Now, we have, as this nerve is talking to the next nerve, there's lots of different ways that actually occurs. And so we have lots of different medicines that have been developed to address those different communication routes that different nerves have. And sometimes we'll pick medicines to put together to treat epilepsy that are very similar because we're trying to really go after one specific communication route. More often though, we'll pick one from one communication route and pick another one from a different communication route so we can kind of hopefully double up and get better coverage and better seizure control. So when your doctors, when it feels like they're just picking medicines, they're actually thinking about some of these different strategies, and sometimes they're purposely trying to go after one mechanism, and other times they're trying to go after a bunch of different mechanisms by putting medications together. Some of those medicines we know work better for what we call focal seizures, where only part of the brain is having a seizure. And some of the other ones we work on work for seizures that come from everywhere at once, which we call generalized. And sometimes we know that some of these medications actually should not be used if your child is having a generalized type seizure. They can make things worse. I'll give you an example that we commonly encounter in TSC. Infantile spasms are those seizures the babies have where they jerk down and jerk their head down. Happen usually when they're only like 4, 5, 6 months old. And for that, and Dr. Gadgil will come later, she'll talk about Sabril or vigabatrin that we use specifically for that. And typically they also have focal seizures, and we're often tempted to use things like trileptal or carbamazepine for those patients who have the partial seizures where only part of the brains. And they're great medicines for that. Unfortunately, in a certain group of babies, that'll make their spasms worse. And so we, in our clinic, we use these medicines, but we try not to use them in those first year or two of life, just in case they're one of those kids where it can make the spasms worse. And then if they're older and they're still having focal seizures, then we'll use those. Or if we don't have any other options, we'll use them. But so we have these medications, when the doctors choose them, they're choosing them based on this understanding of how they work and how they might be put together in a good way. So again, when we choose these medicines, we're definitely thinking about what type of seizures that the child is having. We're cognizant that many of these medications have side effects, such as making a child too sleepy or making a child grumpy. Some of them can affect the liver. Some of them can affect other things in the blood. So we pay attention to that as well. We pay attention to how old the patient is, because some of our medicines are easier to use in babies and small children, and other ones are much easier to use in adults. For example, phenytoin. We certainly can use it in younger children, but younger children actually metabolize medicines very well, and they actually metabolize medicines differently from one day to the next. And phenytoin is very sensitive to that. Versus adults, you and I, we pretty much metabolize the same way every day. And so once we figured out what a good dose for phenytoin in an adult is, we usually can stick with it for a long time. Versus I'll have children where one day they're having seizures and we check their blood level, it's low, and the next day they're kind of walking like they're drunk, and it's because their level's too high. Some other things, lifestyle. If the medication tends to make you sleepy and you operate a truck, for example, we're not going to try to give you a medication that makes you fall asleep while you're driving. So that's an example of a lifestyle choice. Other medications also lifestyle that you have to take 3 or 4 times a day, and that's very difficult, versus medications you only take once or twice. Some of the medications can affect babies before they're born, and so certainly if it's a young adult female or a mother or expectant mother, then we certainly choose certain medicines based on that likelihood that they might have their own child. There's medications that go together really well, and there are some medications that should never be put together because it's just going to be a mess. And so we think about that as well. There are some genetics that play attention to this. I don't know if there's any specific Indian heritage genetics, but one of the most common ones that we have to deal with are patients of Asian heritage, like Chinese, where they can metabolize medications slower than what we would expect. And so we have to sometimes choose medications based on that knowledge as well. And we have tests nowadays that we can actually test people's metabolism and predict those, even though I don't use those very often. We have those tests available. And then we've also paid attention to what's worked in the past. You know, a lot of times we'll have medicine that worked well for a year or 2 years and then it stopped working. And so we start thinking about, well, okay, maybe there's something there that we need to, and it's been 5 or 6 years. Let's go back and try a medicine for that same family. So that goes into that facts as well. Unfortunately, in general, this is not TSC data. This is patients that have epilepsy of any kind. The first medication works about 47% of the time, so about half the time it works. We try a new medication, we get about another maybe 10 to 15% patients who get their seizure under control. You try a third medication, and then you start seeing that your rates of response actually go down quite a bit. This is also true for TSC, but particularly TSC, I think it's even worse. This is a study that was done in Boston years ago, showed that it's between 50 and 70% of patients, when we try to treat their medicines, their epilepsy, they just keep having seizures. And so that's why we started working on the mTOR pathway as a way to treat seizures. Because again, we understood what TSC1 and TSC2's job was. We knew that this didn't work. and we had medications that had been discovered, sirolimus or everolimus, on the Easter Island in the Pacific, this little spot right here, that these medications can help fix mTOR. So this is what happens if you don't have TSC, that TSC1, TSC2 keep mTOR under control. This TSC1 or TSC2 is missing, mTOR is allowed to do whatever it wants. But then we can add everolimus or sirolimus and start to control mTOR again, even if you don't have a TSC1 gene or TSC2 gene that's working correctly. I talked last time about how we use this for SEGA. I'm not going to talk about SEGA today. But when we were doing the SEGA studies, we noticed that there were patients that reduced the number of seizures just by getting treated with everolimus. So we followed that up with a study with 20 patients where most of the patients, 2/3 of the patients, showed a good improvement in their seizures after just 3 months. Okay. We continued to treat those patients for 4 years, and we saw that treatment response in those patients continued. In the majority of those patients who continued treatment. A few of the patients after time did lose their response, but most of those patients who showed an improvement continued that improvement. Now, before we could get everolimus approved by the government, we had to do a traditional, what we call a phase 3 study, where we give some people a dummy pill and we give other people the medicine, and nobody knows who's got the dummy pill and nobody knows who got the medicine. And so that's what we did this trial here. These are the people who got the dummy pill, and so just by coming to clinic, some of them got a little bit better in their seizure control. But you can see those who got a middle dose or those who got a high dose of everolimus, over time their seizures got better. What we know now is the longer you can keep treating patients, the more likely is you're going to get more and more patients reducing the number of seizures. This is the response after just 3 months, which was the main study. 31% of the patients cut their seizures in half or better. Now, most of those don't become 100% seizure-free, but it makes their seizures much, much less. But if we kept treating them out for 2 years, we kept getting more and more patients that cut their seizures down in half, to the point where we had doubled the amount of patients who were what we call responders to treatment by continued treatment long term. The other thing we know now is that it helps to start treatment the younger the patient is. We could start to see this when we did the original study, but as we continue those patients out for longer and longer treatment, we see that those patients who were under 6 years of age were the best patients to respond. And that, but still, there were good responses from these other patients as well. So I wouldn't say that adults can't benefit, but I'd say that it's the little children that benefit the most. Medications always have side effects. These are mouth sores are the #1 thing that we'll run into. And we have ways to treat that. Okay, and I'll talk about that in a second. But the longer you stay on medicine, the less and less you have side effects, including mouth sores. So in our clinic, we'll have maybe mouth sores will start in a month or 2. They'll come and go over the first year. And then maybe they'll have 1 or 2 more over the next year. And then maybe 1 the next year or none. That's typically our story been in our clinic for our patients. Or if they have them, they're pretty mild. But because nobody likes to have a canker sore or an aphthous ulcer is the medical term for that, we have some treatments of things that you can put in the mouth to cover the sore or to make it numb so it doesn't bother as much. We also have some steroids to make the sores go away faster. And we can either use a paste where you can put it right on top of the sore, using your finger or using a Q-tip, a cotton swab. Or what we really like now using nowadays is a solution where you can just rinse it in your mouth and spit it out, which is dexamethasone. In each of these cases, we typically have patients, instead of having a mouth sore that lasts for 4 or 5 days, maybe it'll last for 1 or 2 days and then it goes away. Some of our patients who have lots of mouth sores, and there are some of those patients which they just do have lots of them. We have found in some of them that we can give them lysine, and that will cut down on the frequency of their mouth sores in some cases. We don't have studies that prove this, but it's something that was taught to us by our oncology doctors who deal a lot with these type of problems with their medicines as well. One of the things to be aware of for your doctors is that sometimes you can have high cholesterol or high triglycerides, so high lipids in the blood. And if it's a little bit high, we don't worry about that. But if it starts getting seriously high, first we say you need to change what you're eating. So less naan, less roti, less rice, less candy, and more vegetables and other things that aren't as either high in fat or high in sugar. or simple carbohydrates. If it gets super high, then we have to stop the medication and bring it back down and maybe start a lower dose. Or sometimes if they really need to stay on treatment, we'll treat with another medicine to bring the cholesterol down. We don't like to do that as doctors. We don't like to use medicines to treat medicines. It's not good doctoring. But we have done it in a few patients where really they need to stay on treatment and we want to keep them on treatment. For example, it's the only thing that brought their epilepsy down. And so maybe we'll figure out a way to make it work. Okay. We used to worry about really making kids sick, but that really doesn't happen as much as we worried about at first. So if patients get sick, but they're not sick enough to go see the doctor, we don't worry about that. When it's time when the parents are worried and need to take them to the doctor, that's when we say stop the medicine, make sure that things get okay, and then once everything gets done with the doctor or the medicine, the antibiotic that they prescribe, then you can start back up on the medicine safely. Serious infections can happen, but they're rare. But so we do still take some precautions for patients who look sick or patients who have a super high fever. We do stop the medicine temporarily. We do follow recommendations from other patient populations that use mTOR inhibitors, mainly patients who have transplants. And so we do recommend that they always get their flu shot every year. We do recommend that they go ahead and get any of the shots that don't involve live vaccines. The live vaccines are this list. These are the more common ones. There's a few other ones as well, but polio, MMR, varicella, rotavirus, yellow fever. Those viruses are all live viruses, and so in those cases we have patients stop the medicine temporarily the week before, get their vaccine, wait a week later, and then they can start the medicine again. Okay. The last special thing to know about mTOR inhibitors is if you have a major surgery. And I put two examples in here. This obviously is a child who's had either SEGA surgery or that they more likely had epilepsy surgery. And here we see a scar from a vagal nerve stimulator, which we also use to treat epilepsy. So if it's a minor procedure that can be done as an outpatient, you don't spend any time in the hospital, then typically you don't need to take any major precautions. But if it's a major procedure, you have to stop a week before, go through the procedure. Then when you follow up with the surgeon a few weeks later, and as long as the surgeon's happy that the wound is healed, it doesn't have to be 100% finished healing, it has to be brought together and look good together, then you can start treatment again. Okay. So this ends the epilepsy part of the talk, which shows everolimus is certainly effective for the treatment of epilepsy. And these are epilepsy patients where we've been using all those other medicines and they're just not working. Okay. Will it stop epilepsy in every patient with TSC? No. I just showed you that only after 3 months, only about a third of the patients actually reduce their seizures significantly. But of those patients who stay on therapy, we can get to that to where it's at 2 out of every 3. But that still means there's 1/3 of patients that we still are struggling to control their seizures, even with something like a mTOR. And in those patients, we still want to think about things like the diet, the ketogenic diet. We'll want to think about epilepsy surgery. We'll want to think about vagus nerve stimulator. We'll want to think about things like cannabis that's now is getting more and more evidence for its use. So there's lots of other things still to keep working on if mTOR isn't what we're able to do. We certainly show that in short term it works, and we've shown that that's even better as you do it long term. There are side effects, but most of them are mild, and most of them we can manage as long as the doctor understands kind of what we've done, and we've published this in various papers on how to manage these side effects so that we can keep patients on treatment. Okay. We just recently looked at treating infants and toddlers less than 2, and we've shown that the safety in those patients is about similar to what we see in the older populations. So even though we still probably want to be much careful with younger patients, we certainly can treat babies and we can treat toddlers with mTOR inhibitors. Toxicities or side effects that are really bad are rare, and most of the time, like I said, we have management strategies to keep those patients on treatment. So with the last kind of bit of my talk, I want to talk about sleep. So these are studies that go back a long ways, back into the 1990s, when a researcher by the name of Ann Hunt, who really did a lot of pioneering work in understanding of developmental difficulties in TSC, they did a questionnaire with 300 patients with TSC and found that 60% of them said they were having one type of sleep problem or another. We'll talk about those different kinds. A later study that they did looked at specifically children that were in the clinic. They looked at 40 children. This is children and adults. The children, and they used this special measure called the sleep index. And they found that the higher children had more sleep problems when they compared to other siblings in the same home. So we couldn't just blame it that their home had parties every night and so they couldn't sleep. No, the siblings did not have the same problems. They looked at similar age children outside of the home, which were also very low. And they were actually even higher than children who have other learning problems, which we know often have sleep problems as well. So this was back in the 1990s, what we knew about sleep problems. In Cincinnati, we did a questionnaire back in 2007 called the Sleep Questionnaire. And we also found that there were all sorts of different kinds of sleep problems that were occurring. There were some children who didn't want to go to bed. They would throw tantrums when it came to bedtime. There were patients that you put them to bed and they would stay awake, wouldn't go to sleep. There were some patients who would only sleep maybe 3 or 4 hours every night, and then they were awake for the rest of the day. There were some patients who had what we call sleep anxiety, means they were afraid to go to sleep. Patients waking up in the night. Patients having nightmares or night terrors. There were patients that were having apnea during their sleep. And then there were patients that were very sleepy during the daytime. Okay? So one of the first things when we're talking about sleep problems TSC is you have to figure out what you're talking about. Because if you say my child's not sleeping well, to your doctor, they may understand totally differently what you're trying to tell them. So what you need to explain is whether they're having problems in the daytime, which usually is the form of falling asleep when you shouldn't. I'll give you an example. I have a patient in my clinic where the parents were telling me that the child was not sleeping at night, but then we also figured out that about an hour after they took their morning seizure medicines, the school would let them go take a nap. And so the child would sleep for an hour in the middle of the day, and then they weren't tired at night. So we figured out the problem was we needed to work on their medicine so they weren't falling asleep in the daytime. Then there's the children that just won't go to sleep. You know, you try to get them to go to sleep, and they just fight you and fight you and fight you. And then there's patients who, when they get to sleep, but about a couple hours later they're awake again, and so the family is up again in the middle of the night trying to deal with that. So what do we do to address that? Well, first we try to take advantage of the body's natural way to manage sleep. And all of our bodies have this normal cycle that kind of tells us when we're supposed to go to sleep. Unfortunately, that cycle does not work right in TSC. We've done animal studies, particularly where we've been able to see that they don't cycle like they're supposed to. There's something about the connection to the brain where the sleep is managed that doesn't happen. We also address bedtime habits and routines, and I'll talk about it in a minute. We evaluate medical conditions, I'll talk about that. We treat associated things, and then finally, if we've done all that things and we're still having sleep problems, we talk about medicine. Okay. So this is a circadian rhythm. And we can measure that with body temperature. There's other ways to measure this as well, but this is a body temperature graph where your body temperature starts to rise when it's time to go to bed. Okay? And then it drops while you're asleep. At its lowest point, you wake up in the morning. Then you go up, you eat lunch, and you get a little tired after you've eaten lunch. Okay? So it peaks again, then it drops again in the evening, and then it starts climbing again when it tells you it's time to go back to sleep. Okay? We can actually as human beings, we have the ability to push this. Examples are if we put bright lights, if you stay up late at night and exercising or going out to socialize, or if you eat late at night, we can kind of push this thing later, which means that if you're trying to go to bed at 9 o'clock, but you just got done doing a bunch of activity, you're going to have trouble getting sleep like you normally would. So the first thing we do is we look at trying to make ways for you not to do that if you're trying to get sleep at a specific time. One way we also do that is we adopt good bedtime routines. So we limit late eating. We try to eat earlier in the evening rather than right before bedtime. We also teach the children that their bed or their bedroom is for sleeping. It's not where they play. It's not where they hang out. It's where the body is supposed to go to sleep. So psychologically, they associate that that's what they're doing. We always try to start sleep at the same time. So we start the same bedtime routine. We don't do it at 6 o'clock one night and then 10 o'clock the next night. We try to always do it at a time that is always the same for that family. And that can be early in the evening, it can be later in the evening, but we want to do it at the same time every day. We also do what we call de-escalating activities. So for example, we turn off the television, we read books, we take a warm bath, we we put them in their room where it's a dark room. And you just, and you don't go from, where you're driving on a highway and then all of a sudden you hit the brakes and stop and say, go to sleep. So you kind of just take it down a notch each time, so you can get used to that and you do it the same way every night. For example, when I had my children that were younger, we would start with, okay, about 8 o'clock, we'd say, it's bedtime, let's go get our baths, and we would clean our teeth, and then we would read books together for another 20 minutes or so, and then we'd go lay down in the bed, and we'd kind of talk a little bit, and you just kind of gradually get it to where it's more natural. Okay. In TSC, this is especially important. Medical issues definitely can interfere with sleep. When I talked about my example of a patient whose medications made them sleep in the daytime, there's other medications that can cause patients to stay awake. Some of our seizure medicines, not very many of them, but a few of our seizure medicines actually can be more activating than sleeping. Another example would be when we use ADHD. ADHD medicines like Ritalin can often make it difficult to fall asleep, and so we have to address those as well. Seizures during the nighttime certainly can cause patients to have difficulty sleeping. It can cause them to be waking up at night. It also, either seizures or abnormal EEGs can prevent them from having the normal sleep cycles that the brain is expected to do to be ready for in the morning. So sometimes we'll do an EEG during the nighttime in order for us to know if that's a cause or reason why a patient isn't sleeping well. Okay? And then I said some of our patients, particularly our adolescents and our young adults, can suffer from anxiety, and that can cause them not to sleep well. Other ones can have depression, and that can cause them to wake up early in the morning. So when all else fails, then we start talking about medications. The first things that we do with their seizure medications, because some of our seizure medications actually make patients sleepy. And so if that's the case, sometimes we'll give them an extra amount of seizure medications at night to see if that can help them sleep better. We also have many behavior medicines that we use, and again, many of those can make children sleepy. A common one that you'll hear of is something like Risperidone, and another one we'll use is Seroquel. These are behavioral medications that I don't use specifically for sleep, even though I know that some people will. But if they're already on those medications for behavior, sometimes I'll give them extra dosing at night to see if it can help them sleep better. Then we use a natural medication. Melatonin our bodies make. It also comes in our diet. It's a way that our body tells us that it's time to go to sleep. It's tied to when the sun goes down. And so it's a trigger for us. It's another one that's similar to that is tryptophan. So if say you eat a very large meal, sometimes it has high tryptophan levels in it, and that can also make you sleepy. But these will only help you fall asleep. If I have a child that's waking up 2 or 3 hours after they've gone to sleep, melatonin typically is not going to solve that problem. It just helps them fall asleep. After that, I use medications that are not addictive, they're not habit-forming, but they do have side effect of sleepiness. And some of the common ones I use are antihistamines and tricyclics. These are old psychiatry medications that used to cause people to be sleepy, and so we often use those in our clinic to help with sleep. We use an old, but still used, blood pressure medicine called clonidine. That often makes kids sleepy as well, and it's very safe to use, and so we use that a lot. At last resort, we'll start to use medications that are in the benzodiazepine family. We don't like that because they're not very good sleep medicines. They'll help you fall asleep if you only take them once or twice a week. If you take them more often, that your body gets used to them, and so after a couple of weeks, they don't work well as sleep medicines anymore. Okay. And we've published this too on how the dosing we use for those different medications. So, in summary, sleep difficulties are very common in TSC. It's essential that you figure out exactly where the problem is. Is it a daytime problem? Is it a falling asleep problem, or is it a staying asleep once the child has gone to sleep? Sometimes it's just one of those 3 problems. Sometimes it's all of those problems, in which case we have to start picking and choosing how we treat it. But it's important that when you say my child's not sleeping, that you think about all the different parts of why they may not be sleeping. Lifestyle and behavioral changes are always the first step, not straight going to medicine to make your child fall asleep. You have to go through all these other steps, even though they're harder, because the medications only work so good and really combine with behavior change. Medical issues, frequently we have to look at particularly seizures. So if everything else has been done and there's still concerns about a child that's not sleeping at night, then we'll often want to do an EEG at night to see what they're doing. And then again, at that point we do use medications, and we have lots of choices on how to do that. So that's where I'll stop.